And maybe you can just pull your screen a little bit down so that your face is completely visible. Yeah, that's perfect. That's perfect. Thank you. Okay, so good evening, everyone. I'm Archana Sharma, and I'm the founder of Samvedna Care. Welcome to this very interesting session on role of complementary therapies in Parkinson's disease. We have a very distinguished panelists here today, and our chief speaker. I'm really thankful to Dr. Mina Chandra ma'am for joining us for this very special webinar. As you all know, Dr. Mina Chandra is she's a professor and head of Department of Psychiatry, and she's also head of Center of Excellence in Mental Health at the Atal Bihari Vishisht Institute of Mental Sciences and at the Ram Manohar Lohia Hospital. So welcome, ma'am. Ma'am is a distinguished neurologist, and she has been very kind enough to accept our invitation and enlighten all of us today with the latest updates on Parkinson's disease. And I also have my co-founder and colleague, Dr. Jayashree Dasgupta. She's a project director at Samvedna Care, and she's a neuropsychologist and an Atlantic Fellow in Brain Health. So with two power-packed panelists, I hope we'll be able to do full justice to this session and enlighten everybody and answer questions. So before I begin, just want to set some ground rules that kindly keep yourselves on mute, and in case you have any questions, please type it in the chat window. We have a lot of questions from the participants, and we would be taking them up as we go along. Ma'am would be explaining to us about Parkinson's, in a lot of detail. And this session is also being recorded, so we'll be sharing the recording after the end of the session. A little bit about Samvedna Care. We are a 10-year-old organization working in elderly care and mental health. We have been working extensively in neurodegenerative disorders like dementia, Parkinson's. We have been supporting not only the patients, but also the families of people who are caring for their loved ones. And we are also providing counseling and therapy services for individuals, either who are going through the illness or their families and other members as well. We'll talk more about Samvedna as we get along. But ma'am, over to you. Welcome once again, Jayashree and Dr. Mina. So ma'am, I'll just begin with asking you to just share what is Parkinson's disease and what are the early symptoms of it, ma'am?
So Parkinson's disease is quite a common condition because it is increasingly being recognized. So it was common earlier also, but nobody was recognizing it, nobody was identifying and diagnosing it, and nobody was treating it. It was considered to be concomitant of old age, and so, okay, you're elderly, so maybe you are weak, and hence your hands shake. And because you're weak, hence you sometimes lose balance. So a lot of symptoms of Parkinson's were attributed to being elderly and being weaker in constitution and not to a particular disease. And hence most of the focus was in trying to strengthen the elderly through different nutritional, strategies. But it's quite a common disease, and world over nearly, I think, 8.5 million people have it. India has a huge population, which is aging. We, as it is, have a huge population, and our aging population, because of demographic changes, is also quite large. And with increase in life expectancy, we are seeing a lot of patients who are having diseases like Parkinson's or dementia. And these diseases are also manifesting a little earlier. Earlier we were seeing in 70s and 80s, and now we are seeing in 60s. and 70s. So it's a common disease. One should not feel that it's a very exotic disease, that what has happened. It's just named after Parkinson's. And the symptoms are also quite common. Usually it starts with mild tremor, maybe of one hand, one extremity, and later on all the four limbs and even truncal tremors might happen. And there might be difficulty in maintaining posture, difficulty in maintaining balance. So people tend to either fall down or stumble quite frequently. And we attribute it often to poor eyesight, but it might be due to poor balancing. And when you ask people to suddenly, turn around or shift their balance, and this is also a time when they are often become unstable and might shift. Another thing which happens with patients of Parkinson's is they become very slow in doing activities, what we call bradykinesia. That in all activities which they are able to do, they are very slow. So a simple thing which takes us 30 seconds might actually take them a minute or 2 minutes. So slowness in walking, slowness in feeding themselves, slowness in dressing themselves. So slowness becomes a very important factor. Another thing which is often seen in Parkinson's, it is one of the triad of Parkinson's is rigidity. People become very stiff. So their arms are stiff, their legs are stiff, and sometimes they stoop down because they're so stiff. So traditionally, difficulty in maintaining posture and balance, ataxia, rigidity, and tremors is the triad of Parkinson's. But other symptoms are also known, like memory difficulties, sleep disturbances, appetite disturbances, sensory impairment. So it is a spectrum of these symptoms, and not every patient will have all. Some patients might have some. As the disease progresses, symptoms become more severe, and more symptoms also add in. So that is also a way in which we know that the disease is progressive. It is a neurodegenerative disease and it tends to progress over time, but there are therapies available, both pharmacological and alternative, wherein we are able to reduce the discomfort, reduce the suffering. Uh, we may not be able to slow down the progression of neurodegeneration, but if Parkinson's is due to other causes, like we also have drug-induced Parkinson's, then obviously we are able to bring about reversals of a lot of symptoms. Or Parkinson's might be secondary to injury to the head, multiple head injuries, and then there are other treatments. But the classical Parkinson's, which is due to genetic causes, they obviously will not remit. There is no cure, but we can obviously help patients be comfortable and have a good quality of life. So that is the initial introduction.
Thank you for sharing this, ma'am. So, as you mentioned, it's a neurodegenerative disorder, and it's not. Unfortunately, there's no cure for it, like many other neuro illnesses. So, what are the risk factors for Parkinson's, and how can the younger generation take certain precautions, or even um, s- older adults, I would say, and what would you advise? What are the risk factors and what's your advice to them?
Okay, some of the risk factors in our medical books are, non-modifiable. So, like age, as we uh, are blessed with older age, then the risk for Parkinson increases. So one may not develop at 60, but one might develop at 85. So if one is blessed with 85 years, then the risk for these diseases also goes up. Then amongst gender, male gender is at increased risk. People who have non-communicable disease, especially uncontrolled non-communicable disease like uncontrolled hypertension, uncontrolled diabetes, they are at high risk. If one is exposed to environmental exposures like metals and toxins and fertilizers, those people are also at high risk. Further, if one is also exposed to multiple head injuries, like boxers and people who have suffered falls and head injuries, then definitely higher risk. And finally, genetics. If there is a family member, a first degree relative who has Parkinson's, then there is a higher risk for Parkinson's. So you can see that most of the risk factors are not modifiable. So it is like a Russian roulette. One doesn't know if one is going to be susceptible for Parkinson's. The best thing is to maintain a healthy lifestyle, keep all our NCDs in check. And if Parkinson's develops, we identify it early before there is, large amount of neurodegeneration and a lot of symptoms. So early in course of disease, if we intervene, we can restore a quality of life to the person. We can also help a person go through the initial stages of Parkinson's with near normalcy. But obviously, in later stages, it is a challenge.
So, ma'am, what are the early signs to look out for? Are there any key, biomarkers or like key identifiers to look out for?
Yes, so the various biomarkers are research-based biomarkers. Clinically, it is a clinical diagnosis best made by a neurologist or a psychiatrist or a specialist physician who has experience in neurological disorders. And one of the earliest symptoms is tremors. So a slight shaking of hand, or if the handwriting starts deteriorating or becoming smaller, micro handwriting. And initially, the patients might complain that the bank people say that signatures don't match. So the impact on writing is something that is initially seen. Then we have patients who come with history of falls, and when we ask them, how did you fall? They said, we fell because we stumbled. We fell because we turned rapidly and just could not control the balance, and or something, happened suddenly and they were startled. And when they were startled, they couldn't maintain their balance and they fell. So history of falls is also very important. And another thing which actually the family members complain far more than the patients is that they are very slow. And sometimes family members believe, and wrongly so, that they are deliberately so slow, that they are taking a long time to feed themselves or to dress themselves. What is there? Why don't they just finish their dinner in time, and why don't they just button up their shirt and get dressed? But it would be a challenge for someone with Parkinson's to, carry out tasks with the swiftness which is expected in so-called normal people or in their younger age group. It is slow for them. It is a challenge, and when we start treatment, that is the initial response that we see. The patient said, now we are, able to do our tasks a little faster and without much clumsiness. So those are the initial signs that we see.
So what are the treatment options available for Parkinson's, from the pharmacological aspect? And then I'll come to you, Jayashree, to also discuss about the complementary therapies. I'll probably address this to both of you. But in terms of the treatment options, ma'am, what are the best treatment options available for this? I think Dr. Mina's screen is frozen. We'll just wait for her to come in. Am I audible? Jayashree?
Okay. Yes.
Okay. So maybe Jayashree, I can request you to come in the meantime and, talk about the role of complementary therapies in an illness like Parkinson's or, similar neurodegenerative disorders.
Definitely. I think Dr. Mina will, talk about what, the routine interventions and treatments for Parkinson's disease are. But when we talk about complementary therapies, one thing that's important to understand is what we mean by complementary. And by complementary, these are usually interventions or treatments and therapies that are add-ons to the routine kind of interventions that a person is seeking for Parkinson's disease. And these include an array of interventions. In fact, the research shows that most people, globally, actually use some or the other form of complementary therapy alongside, allopathic interventions. And these can be things like yoga, meditation, other forms of exercise. Acupuncture is quite, common, for example, in China, Tai Chi. Therapies like music therapy, dance therapy. There's in fact a lot of research which is going on to try and understand how particularly dance and movement therapy can help people with Parkinson's disease. And then, of course, specific interventions that are more symptom oriented. So we were just talking about, how handwriting changes. So interventions for some of these kind of, challenges that people with Parkinson's disease often experience. So these are really some of the common complementary therapies that most people often engage with alongside the traditional interventions for Parkinson's disease. So yes, we can definitely talk a bit more about these going forwards.
Sure. I just saw Dr. Mina was back. Ma'am, can you hear us? Ma'am,
Yes, I can.
Okay, great.
Yes, I can.
Okay, wonderful. So I just asked Jayashree to fill in while you were joining back. So ma'am, over to the question which I was addressing to you. Can you share the common treatment options available for Parkinson's, and how do you go about it? Like you mentioned, neurologist or a psychiatrist are probably the best people to diagnose it. So what are the treatment options available, ma'am?
Yeah, so the mainstay of treatment is pharmacological, and there are medications like commonly called Syndopa, which is levodopa plus carbidopa combination, which we have to start at a low dose and slowly, as required, we escalate. And there are other medicines like entacapone, which is often used. Then there are other treatments like surgical interventions, like deep brain stimulation. So that would be a surgical. Another thing which has become quite popular nowadays is neuromodulation, RTMS, and TDCS, which is the repetitive transcranial magnetic stimulation or direct current stimulation, basically trying to stimulate the area of the brain which has got impacted and which is resulting in the symptoms of Parkinson's. So the mainstay of treatment is basically to help address the symptoms, either through medications or through surgical or neurostimulation kind of interventions. There is no cure, so the treatment is not aiming at curing Parkinson's, but then treatment for diabetes is also not aimed at curing, diabetes. So this falls in the category of hypertension or diabetes or dyslipidemia, where medications help us control symptoms, control processes, and result in a better quality of life. So one should not feel too disappointed, because when people start with any new disease, they are looking for quote unquote cure. But as age progresses, cure is not a therapeutic goal. Cure is not a treatment goal for Parkinson's. At the same time, it was not a treatment goal for hypertension and diabetes, which started in 40s, 30s and 40s. So if one accepts that, and one is only when one accepts that one can move forward, then medications can give a good quality of life, help in activities of daily living, help a person discharge his life duties, have a good interpersonal relationship, have a good social adjustment. So the benefits of treatment are beyond cure also. So that is something I wish to impress. So many times people just stop treatment thinking that if it is not curative, what is the point? But what is the point of suffering when treatment to reduce suffering is easily available? It is available in most hospitals. The medications are also not very expensive, and at least we are very sure that they work. And in early and mild to moderate Parkinson's, they work really well, so that a person can have a near normal life. One can participate in his family life, travel, leisure, manage finances. The problem comes when it is severe Parkinson's, or when other things also set in, like dementia also sets in, or there are some falls and then they break, their femur, there is some fractures. So the concomitant conditions are the ones which reduce the quality of life of people with Parkinson's more than Parkinson's itself. Because for that, there is an effective, symptomatic management option. But yes, other conditions, when they do set in, then the quality of life and social engagement and productivity, it all comes down.
Right. And ma'am, I just wanted to ask you, you mentioned about, deep brain stimulation and some of these other modalities. So how successful are they, and in what cases would you actually recommend patients to go through that?
So I don't think so I've ever recommended anybody for deep brain stimulation.
Okay.
Because it's an invasive procedure. Parkinson's is a disease for the elderly. They already have so much of comorbidity.
Right.
But RTMS, which is the repetitive transcranial magnetic stimulation, we have it in our hospital in both departments, psychiatry and neurology. It's very effective. You do 2 sessions a day. There's a protocol for Parkinson's, and it's available in private practice also. And it's pretty effective because it is stimulating the area of the brain which is not functioning optimally. And there is no side effect, literally, though there could be minor things like headache or tingling or something. But it's very well accepted, and there is no anesthesia required. Patient is awake throughout the procedure. Patient's family members can sit with the patient throughout the procedure. It's not that patient is taken to another intervention room or an operation theater where you don't know what's happening to the patient. And they're brief procedures, 10 minutes, 20 minutes long procedures. You can do 2 sessions in a day, which is typically a protocol that we follow. Space 1 hour, they have a cup of tea and and they come back. So in terms of acceptability, safety profile, tolerability, accessibility, I think RTMS can be a very useful adjunct treatment. It is not going to replace Syndopa, so let us accept that, but it is certainly going to strengthen the role played by Syndopa, and especially when Syndopa's effect is starting to wane, or we want to reduce the dosages, because with time the dosages increase. So when we give Syndopa, then we are also mindful that there might be a time when the effect might plateau, and we don't want to have that. We don't want the effect to stagnate. And RTMS is a very good modality to prevent stagnation of response. And it is completely safe. And it is such an open kind of intervention. One is sitting on a chair and RTMS is applied. Family member is sitting. The doctor is also sitting, or a technician is sitting. One can talk through the procedure. So it is... and that is the reason why it is so acceptable, even in private sectors where it is quite expensive compared to government sector, that one sees the response, and there is no fear that the elderly patient is being subjected to some kind of unknown procedure, because one walks in and one walks out. There is no sedation, there is no medication. Literally, one can give an appointment, do the procedure and go home.
Okay.
So RTMS is something that I would recommend as a modality, but in specific cases, only the treating neurologist or psychiatrist can tell. But then Syndopa and entacapone also, um, it it strengthens the effect of Syndopa. So that is another medication that can also be given. But beyond that, I think complementary therapies, start featuring. So
Right,
this is the mainstay of medical management.
right. Yeah, and like, you mentioned about socialization and, engaging the person, which I think is very, very important. And Jayashree was also talking about how, you can engage uh, patients in, art therapy or music therapy, handwriting practice. And we have had some cases at Samvedna where we have very diligently, worked with the patients using music as a tool, because music is, it exercises all your jaws and, all your other motor functions. So, Jayashree, want to come in and add anything more to the complementary therapies which we spoke about?
Yeah, sure. So I think, as Dr. Mina was mentioning, that the mainstay of intervention is, of course, the pharmacological intervention, which is very critical to keep in mind. And I think, ma'am, you made a great point that, the goal is not cure. It's really about management, and that's very, very important to keep in mind. Um, and the complementary therapies really come in, as we were just discussing earlier, they're complementary. The aim that these therapies have is really to improve the quality of life
Right.
of the person living with Parkinson's disease, and also the caregivers and other family members. So a lot of these complementary therapies, the research has actually shown that they improve the quality of life. So, for example, if we're talking about music as a complementary therapy and the kind of role that it plays in Parkinson's disease, it's like the benefits of this are almost twofold. I think everyone will agree that music has a capacity to uplift someone's mood. And because of and I think Dr. Mina can probably talk to some of the biochemical changes in the brain a bit more, but that itself can, the music itself can also impact the dopamine release in the brain and activation of the limbic system, and maybe that's some of the mechanism through which music is actually helping people with Parkinson's disease as a complementary therapy. So I think these therapies are good adjuncts. They're good to kind of layer on. Again, keeping in mind that the aim of these therapies is to improve the overall quality of life of the person with Parkinson's disease.
Sure, sure. Well, thank you for sharing that. And I think both and dance therapy, like dance therapy is also something, ma'am. We have had patients who have been recommended dance as a form of movement therapy for, to help with the stiffness of the joints and, so would you like to comment on that?
So I think all kinds of movements help the patient, because sometimes because of stiffness, people avoid movement. And when we encourage them and help them move, then sometimes the stiffness also reduces. Because of disuse or not using all the muscles and joints in our body, people tend to become a little bit more stiff. And when we help them move through either a dance or tai chi or yoga or any stretching exercise, then we find that the patients tend to respond, and their stiffness reduces, their balance also improves. So with dance therapy, not just the movement becomes more agile and the range of movement also increases, the stiffness comes down, the balancing also becomes better. So and obviously dance therapy also gives you a lot of happiness, joy. So serotonin being released and dopamine being released, all those wonderful neurochemicals also help a person with Parkinson's, at least some micro help. It does not again cure the disease, but it makes the life more comfortable. Another thing that I want to say is a lot of these therapies are held as group therapies.
Yes.
And the advantage of group therapies, including, affiliation, social engagement, reciprocity, mutual respect, dignity, all those processes are also very precious,
Right.
especially for a disease which does not have a cure. So, by giving a platform to people, by giving them their own so called tribe, with people with Parkinson's or with dementia or other such disorders are together in a room and trying to find joy in life through a group activity. So, the group dynamics is also very engaging, and group dynamics is also very rewarding. And obviously, there's a moderator who handles in case some group dynamic is adverse. So I think we should also understand that a lot of these therapies work through group engagement, and because nowadays, especially after COVID, everybody wants an online therapy, but online may not work so well because the social engagement, the exchange of ideas, emotions, the resonance that one feels in a group of people, that is not there. So that's very impersonal in a virtual world. But be that as it may, if there is no therapy available, then a virtual therapy is also acceptable, but it's never as good as face to face or group therapy. Another kind of therapy that is useful. Uh, okay, another kind of therapy that is quite useful in persons with Parkinson's is small crafts, arts and crafts, allowing them to paint, allowing them to do clay modeling, allowing some dexterity, making rangoli, making henna patterns. It is artistic, it also engages them, and it is rewarding, and it's culturally accepted. So it is not like something which is, a completely Western model. One, uh, you know, common psychological fact is whatever we pay attention to actually magnifies in our mind. So if we are paying attention to stiffness and balance issues and symptoms, so they tend to, occupy our mind and we become preoccupied with them. And when we are focused on, that there is a small group therapy that I will be going this evening, then obviously I'm looking forward to that engagement and looking forward to the joy that comes from that engagement. So the focus of patients with Parkinson's is actually shifted by all these complementary therapies. From a completely physical focus and a deficit focus that we could do this and we are no longer able to do this and this and that, and a focus about their inabilities, their deficits, and victimhood. Why did this happen to me? What did I do to deserve this? All those narratives are washed out when one is happily engaged in some complementary therapy, be it art, be it music, be it dance, crafting, aromatherapy. So, complementary therapies also help us by balancing our focus, by reducing the morbid focus on disease and its symptoms and its incurability to something that we can still find joyful, resonant, engaging, pleasurable. So the humanity of a person gets reinforced when when we are engaged in complementary therapies, and that is why they are so popular. Complementary therapies are never claiming also to be curative. But why are they so popular? Because they are able to engage a person as a human being, as a dignified senior, despite deficits. despite symptoms.
Yeah.
So I think that is such a precious position to be in, that one is accepted, one is loved, one is engaged with like-minded people.
Mhm.
And complementary therapies offers you that platform, which is not seen in a traditional medical consultation, which tends to be clinical. I'm not defending it, but it tends to be clinical, and it tends to be very structured, and it tends to be many a times with certain neurologists and psychiatrists. It also tends to be impersonal, but patients are looking for more, and people who are able to engage with the patients, have a good rapport, are able to help the patients better. And it's also clinically more satisfying when one is able to engage. And sometimes we also recommend so many complementary therapies like arts, mandala painting. It is the recent, new thing, but elders are, focusing on adult drawing books in which you have patterns, and not cartoon characters, but patterns and cultural motifs. And it's a wonderful way to spend your time as an elderly, with or without Parkinson's.
Absolutely.
Yeah.
No, ma'am, thank you for sharing this. And we have had a lot of these experiences also in complementary therapies. We work a lot more with dementia than Parkinson's, but we do have people who have Parkinson's also. But yes, like you said, it's all about the human touch, and it's all about the engagement, and what that person is looking forward to that day, and improving his or her quality of life, which is, I think, the primary objective of these therapies. Um, just to circle back on the clinical aspects, ma'am, there was a question about what are the side effects of these medicines like Sindopa and others, and do they also tend to bring in any psychiatric issues? This is a question from one of our audience members.
Yes, so any medication has a side effect, but doesn't mean it would occur. So because sometimes the side effects get
Yeah. May I request everybody to please be on mute? Yeah. Yes, ma'am.
so when we talk about side effects, sometimes people believe that side effects would occur for everyone. Actually, side effects are rare. If they were to occur for everyone, then the medicine would never be approved. Number one. Number two, if side effects occur, and you tell your doctor, he would be the best judge to reduce the medication, change the medication, or take a decision. Many a time, concomitant symptoms, either de novo symptoms or symptoms due to other causes, get attributed as a side effect. Anything new that happens.
Mhm.
So very popular example that I tend to give is, you started on this medication, after that it rained. Did the medication cause rain? They said, no, ma'am, what is this? This question is absurd. I said, precisely, it is meant to be absurd. Every new thing which happens after you start a medication is not medication related. Some could be change of season related, right? So there could be a change of season, and people might develop cough and cold or something. Common side effects could include headaches, could include dyspepsia, could include epigastric discomfort, could include a little bit of dizziness. One of the more and also insomnia. One of the more serious side effects is emergence of psychiatric symptoms, which can also happen with medications like Sindopa, but they are easily controllable. So a person might have emotional outbursts, or might become emotionally fragile, or might see things or hear things not seen or heard by others, or might develop a false belief about somebody trying to harm him, or somebody trying to steal, or people talking about them. Yeah, so those kinds of false beliefs and experiences, like sensory experiences, might develop. But when they develop, we know how to treat, and a good psychiatrist is able to take care of them. So those are the symptoms which can be easily treated as compared to symptoms of Parkinson's. So side effects are easily treated. The effect is something that we have to work on and be very mindful about. But side effects are very easily treated.
So, Jayashree, I have a question for you. Like, we spoke about the psychiatric symptoms like depression and, psychosis sometimes, cognitive impairment, and then hallucinations, anxiety. So, what would you recommend as a psychologist, how people can support their loved ones when such symptoms manifest, other than the medication? But what is your advice for the family? This context.
So, in fact, depression and anxiety are quite common in Parkinson's disease, and it's there's two aspects to this. Almost, I think, about 50% of people with Parkinson's disease develop depression at some point in their lives. About 40% with develop some sort of anxiety. There's some research and indications to show that maybe people develop depression before the before the early symptoms of Parkinson's disease, and then of course once you're diagnosed with something like Parkinson's disease, then people can feel depressed because they have a condition like this as well. So it's quite complex. But one of the things that's important to remember, particularly when we're talking about depression and anxiety, is that there are things that you can do to help address these symptoms. And depression is more than just feeling sad and upset. Depression is when it's actually impacting your ability to engage and enjoy things that you used to do before.
Right.
And that's sometimes family members and even people who are experiencing depression struggle to understand, is this something for which I should seek help? Or what should I do? When am I really depressed, or am I just making a big deal out of nothing? And if you're struggling with something, why not go and speak to someone about it? Sometimes medication can be helpful, but sometimes just speaking with a psychologist and trying to understand, process what's going on could be related to other things that are happening in your life. That can also be very helpful. So I think the first thing to remember is that if you're struggling with something, you're not feeling as joyful, you're feeling sad, you're upset, you're just struggling, then that's itself is an indicator that you should try to do something about it. Of course, with depression, this impacts other aspects of your life as well. It impacts your ability to engage with your work. It can impact your functioning in your family life. It can impact your sleep. It can impact your appetite. So if you're experiencing a couple of these changes, and these have been fairly prolonged, we usually say clinically if it's more than 2 weeks at a period, and it's a mixture of all these things which are getting impacted, then that's a good time to just reach out to somebody and talk to them, a professional, and see if there's something that you can do. And just sometimes understanding what you're experiencing, talking about it with someone itself is that first step itself can be very helpful. And as family members, I think the biggest thing that we can support an individual with when they say that they're not feeling up to their usual self is to not brush it under the carpet, to be there to support that person, and just offer support and ask what you can do to help them, and also to not kind of stigmatize seeking help. Right. Because the biggest, I think one of the most challenging things that we see as clinicians, and is that sometimes these problems, people experience them for a fairly long period of time before they actually reach out to somebody, for a professional, for help. So why sit and suffer for longer when there are ways that you can deal with this, and it can be helped. There are a lot of myths and misconceptions around, like, oh, if I take medication for depression, will I need to take it forever? Will I need to, what will people think of me if I go and meet a psychiatrist? Will they call me mad? Is it, what if people get to know I'm seeing a psychologist? And these are places where I think, everybody in the family can be supportive. People, so that we don't actually stigmatize help seeking. because it's important to take that first step, and it's important for if someone is expressing that they're not feeling up to their usual selves, or family members are able to notice this, that they're in fact encouraged to do something about it. So I think those are small ways, but very important ways in which family members can help someone.
Well, thank you for sharing this, Jayashree. Definitely, I think what I hear in my circle is tabiyat theek nahi hai. So people are not willing to call the illness it is, and they try to. It's just mood disorder, or any mood swing is just considered to be a part and parcel of the life, and abhi tabiyat theek nahi hai, and it will become okay in some time. So I know I can see where you're coming from, and I think seeking help in time. My father, when he was diagnosed with Parkinson's, he was also advised certain depression medication, because the doctor could see that he was also, getting depressed. And so then we as a family, of course, worked on seeing how we could give him a quality of life. But there was a time when he was on some certain antidepressants for a short time. So that's a part and parcel of the illness, like you are sharing. So ma'am, actually just wanted to ask you one more question, and this is from one of the audience, that is dementia inevitable in Parkinson's disease, or does it happen in certain percentages of people? Like, because a lot of time people come to us and say, my father has Parkinson's or my mother has Parkinson's, and when we recommend to them complementary therapies, they kind of shy away. Say, "नहीं, नहीं, they don't have dementia and abhi kuch nahi hai." So
Yeah, so this whole, game between two polarities, my family member is sick, or my family member is not that sick. My family member has an issue, but my family member does not have other issues. So, it boils down to acceptance that there is a disease process. Another thing, I wanted to say, taking Jayashree's point a little further, is when people start complaining about being sad, or they are emotional and they're crying. Sometimes family members are very judgmental and say, "Why are you sad? What has happened? We are giving you the best lifestyle." Because they think that depressive symptoms are, an indictment for the caregivers. But it's just a biological fact. It might have something to do with their social situation or family situation. Many times it has nothing to do with their family situation. It is just because there are some neurochemicals in the brain which have gone haywire, or they might be having long-standing depression which was never treated, and now in older age with setting of Parkinson's, it is no longer masked, it is coming forth, and there is a cry for help, that okay, you are helping me with my movement, please help me with my emotions too. So I think we should stop being so judgmental about people needing help for their, even if it's an emotional issue. What's wrong with having emotional issues? If one has emotions, one would have emotional issues. If one has a brain, one could have any neurological or psychiatric disorders. Coming to your question about is dementia inevitable? No, it's not inevitable. Not everybody would have. Who would have is, there are risk factors. If you already have somebody with dementia and Parkinson's, more at risk. If you have non-communicable diseases like uncontrolled hypertension, diabetes, dyslipidemia, coronary artery disease, more at risk. If you have a history of head injury, more at risk. If one has consumed a lot of substance in adulthood, going on to middle age and older age, including alcohol, tobacco, other things, then yes, cognitive decline is more likely to occur, but it is not inevitable.
okay, right. No, thank you for sharing this, ma'am. There's also this in the Western context, I think, and this keeps coming to us in many forms. What is people advise CBD or marijuana, as a as a treatment for a respite from Parkinson's symptoms. So where are we on this in the Indian context? Is it legal? Is there any policy decision, anything happening? Is it not proven? I'd like to hear your views on this, ma'am.
Yeah, so there is a lot of interest in the West about marijuana, CBD oil. In India, there is a cultural acceptance for, bhang and ganja. There's a cultural and religious acceptance. So for us Indians, it is not so exotic that we are looking for a panacea in bhang and ganja. But in Western perspective, where they were very puritanical, it was heavily either restricted or just completely open, like in Netherlands. So they're trying to find some medical indications or justification. So one medication can have a justification for one illness, one cannot have it for all. So currently CBD oil is being explored for a variety of indications, not just Parkinson's. The evidence is very limited, and evidence is not being reproduced. So scientifically, it cannot be or should not be given. If people are taking it, they are taking it on their own. If somebody is using recreational bhang ganja, they are doing it on their own, but not on medical advice and not on therapeutic purpose, right? So the research evidence is not there. CBD oil has been promoted for a variety of, reasons, and marijuana has been promoted even for pain, for cancer patients, intractable pain. Yes, there are pain pathways which are addressed temporarily by marijuana, but those are not Parkinsonian pathways. So the evidence and the scientific rationale for CBD oil, as per the current evidence base, is very limited.
Thank you for clarifying this, because this is very good to hear from a doctor's point of view. So we are actually almost coming to the end of this session, and if there are any questions the audience has, may I please request you to ask? Yes, Shri Chand Suneja, please, you can ask your question, sir. So can you just unmute?
I am unmute now.
Yeah.
Thank you very much for sharing such a important topic, which is really a deadly disease. And my question was already put in my chat box in the beginning. You asked for what could be the preventive actions? Today maybe at every age you're fine, everything is good, and suddenly you come to know that you have a Parkinson's or dementia going on. So what are the preventive actions one can take not to have it, or maybe at least prevent or delay it out if it is something likely to happen also? So what could be those things, if you can suggest? I think that would be very useful for all of us who are attending this session. Thank you.
So one cannot prevent Parkinson per se, but one can reduce the risk for Parkinson's.
Okay.
By controlling your lifestyle, controlling hypertension, diabetes, all these lifestyle diseases, by being generally fit. If one is frail, then posture instability is more difficult to manage as compared to when one is fit. So physical fitness, age appropriate exercising, that's very important to build up on your muscle strength, build up on your posture, build up on your balance before Parkinson's strikes. So people who are better maintained find an easier journey to negotiate as compared to people who are already frail, and then they find it difficult. If one is taking any substance, alcohol or tobacco or anything else, quit. Now is the time to quit. Because all these substances, they give you a high by acting on the brain, and brain is the place where Parkinson's is generated. The genesis of Parkinson's is through the brain. So if one can reduce the burden of substance on the brain, that would be a wonderful idea. And general lifestyle, so that would be true for any elderly, for any disorder. If you are generally fit, if a disease like a hereditary disease or a genetic disease like Parkinson's strikes, you will be better off as compared to someone who's already frail and not well maintained, whose general condition is not so good. And if one can prevent head injury, if you're driving on a two-wheeler, please put on the helmets. Sometimes people believe that they're going to the local market. What's the need for the helmet? It's not mandatory, but it is. The helmet is there to protect your head. And one can only look at statistics that, how many head injuries were preventable because people were not wearing helmets. Especially women don't like to wear helmets. And they feel that putting a dupatta on their head is sufficient. It is not sufficient to protect the head. So try to be very mindful about, head injury. General measures at home, try to prevent falls. Try to, do yoga or some light exercise. Try to have some grab bars or you hold the banister if you're climbing stairs. In the toilet, if it is, you can have some grab bars so you don't slip. Because head injury is one of the significant contributors to Parkinson's. But the genetic Parkinson's, that is something which is genetic, so it cannot really be prevented.
Fine, I think that's a good answer you gave. So I think yoga, what you said, and yoga and meditation, the actual, like Buddha CEO is coming up very well in a way, and I'm a part of that, attending that program for 40 days. So do you agree with this also, that the meditation and yoga, you did mention, of course, yoga, are very helpful for this, and of course the head injury prevention is equally important, but anything to prevent eating other than the alcohol, tobacco, and so on. So, and just to tell you, I have done more than 300 people, non-smoker or non-tobacco eater, in my life way last 20 years time, on record in a way. And I have been really promoting very well to be making sure that people really quit such kind of a bad thing, which is written on the packet that eating this, you are living to be with the cancer or things like that, deadly disease you will have. But back to eating, anything preventable or not to be eaten in specific, or anything to be eaten which would help to be preventing this disease?
Yeah, a good balanced diet always helps.
Okay.
And trying to control lipids, cholesterol, fried food, and avoid excess of salt. We in South Asia, the Indian subcontinent, we tend to eat a lot of salt.
Okay.
And our food is also salty and fried, and we tend to eat namkeens and all these biscuits. So our salt intake, sometimes our salt intake is quite high as compared to Western population. And sometimes people put even salt in dough. In the roti atta, they put salt in that. There's salt in the salad. There's salt in raita. There's salt in papad. There's salt in pickles. So apart from dal and vegetables, there's salt in everything. Apart from water, everything has some salt in it. So if we can reduce salt and make an intentional effort to reduce salt, that one would not put salt in raita, one would not take papad, one would not take, anything which is packaged, because salt is used as a preservative. So reducing salt is a challenge because our palate is driven for salt. All our, chaats and pakodis have a lot of salt. All our outside treats have a lot of salt. So reducing salt. Everybody is bothered about sugar because of the diabetic, epidemic in India. But salt is something one has to be very careful about, especially when one grows older with reduced kidney functions. Salt is something you should watch out for.
But adding to the salt, when you said there are 3 varieties, we talk of kala namak, senda namak, and this normal iodized namak, what we take, Tata ka and jo bhi hai. Which is the anything amongst these 3 varieties? Is it that you should stop iodized salt or otherwise something like that?
No, all salt is equally bad, especially for elderly.
Okay.
And we should all take low salt diets. I'm not saying a low salt variant. I'm taking total amount of salt should be low. And Indians are having a lot of salt. And
Yes.
we never realize it because it is cultural.
Yeah.
But as we grow older, our salt requirements are less. And sometimes when there is extremes of temperature, we can also have electrolyte imbalance. Sometimes salt falls sometimes salt rises. What has happened is we are so used to of taking high salt diets, and changing the palate to a lower salt dietary plan is not easy, because for 60, 70 years we have taken salt, but it should be done.
Yeah.
I appreciate that. Thank you very much. In fact, I just had chutney pakoda, and so I
Yeah.
think that's all covering everything in a way. Yeah.
So,
Okay.
we have
all
just
our-
time for one more question, ma'am. So there's Mr. Chino San. Would you like to come in? Mr. or Miss, I'm sorry.
Yeah,
Yeah,
good evening,
sorry.
doctor.
Yeah.
My question was, my father actually has a PSP CBS. And the thing is that he's been diagnosed with this since November last year. So initially with Syndopa, he was doing very well for 2 months. But after that, he started complaining of, feeling dizzy while he is walking because he is looking down. So the main chief complaint is whenever he looks down, so he is feeling this dizziness, and the balance is like he loses out on balance. But otherwise, everything is okay. So even when he's watching television, which is, the posture is not very well maintained. So the doctor has advised him to be, you have to sit in a proper posture, because cervical was also the issue. So the normal activities have been hit. So in that case, if you can suggest something, throw some light on that. How do we go about it?
So the patient has progressive supranuclear palsy,
Yes,
PSP.
yes.
Yeah, so it's a difficult disease to take care of. One of the things that you can do is you can have a seating plan for him, a specific seat for him. It could be a sofa seat, it could be a recliner, where his back, upper back, shoulders, head is supported. Right. So you need not buy anything. You can also do the same thing with a couple of pillows and masnad. But his posture has to be supported through pillows. Just like with children, we tend to, put bolsters on the side so that they don't roll off.
Yes,
So
ma'am.
with a person with PSP, that would also help, that you have posture where he is standing, even when he's sitting. In case he has some difficulty with walking, you and your home has enough space for a walker. The walker would help, because then he won't be looking down, right? And he's having dizziness, especially when he's looking down. So a walker would help. And other than that, he can be engaged in nearly everything, because other symptoms which are seen in Parkinson's would not be there. So he can be engaged psychologically, socially, emotionally, cognitively, with a range of happy activities. So you just make an inventory of activities which are meaningful for him, introduce some new ones also, and have someone play out the activities with him. You can also do cognitive stimulation. So many things you can do in the complementary and adjunct treatments, because PSP is not going to limit him so much. Yes, it is a serious illness, but we have to work with the limitations and not look at the deficits only.
Right.
True. He is very well responding and doing his bit, and he's doing very well otherwise. But the only
Yeah.
thing is while walking only, because physiotherapy has helped him a lot. And
Yes.
initially the balancing was, an issue. He was not able to walk without a walker or so. So that even that he is not taking as of now. The only prime concern is, whenever he's looking down, so that he's careful about himself, so that he doesn't want to fall. So that is the only issue that he's facing. So
Yeah. You can tell him that instead of looking down as he's walking, he should look ahead and see that the pathway ahead of him is clear.
correct.
Then he would not need to look down. So if he can maintain a 30-degree gaze and look ahead
Correct.
instead of looking below. So if the pathway is clear, then he's safe. And he just needs to have confidence that I've already seen the path. I don't need to revisit and look at my path again. And I don't need to look below. And try to have your home clear of all impediments and all small things that we tend to drop about, because elderly tend to stumble. So that is always a fear. So if there are small children, see to it that nothing is left on the floor. So when he is walking, there is a clear passage. from where he's sitting to wherever he's going.
Sure.
Great.
And if I may, there is somebody who has been also texting me on LinkedIn and also on this fora. If you wish to take consultation from me, my days are Tuesdays and Thursdays. I sit in room number 4, psychiatry OPD at Dr. RML Hospital. You can bring your patient or you can have the patient visit me on Thursday. That would be my next OPD, but I cannot give a consultation on a public platform without seeing any patient. And that is not the way one does clinical practice. But Tuesdays and Thursdays, room number 4, psychiatry OPD, Dr. RML Hospital. Very happy to see any patient. So that goes out for other patients also.
Yes, ma'am. Yes, I was actually going to add to that. Thank you so much for sharing. So, Anuja, I hope your question has been answered because you had raised your hand. I don't know if she was the one who's asking.
Yeah, good evening.
she
Thank
was.
you. Thank you for giving notice to my messages also.
Sure.
Yeah, so actually the situation is very complex and perhaps like what diagnosis Dr. Lokesh from RML has done is it's basically his Parkinson is genetic, and then he was on a dosage for like 1.5 years, the same dosage. And last year also we had shown him in RML, but it was in medicine. So the psychiatrist only visited, but they had not asked us to reduce Indopa. But this time they've asked us to reduce Indopa, analyzing that it is.
Yeah, ma'am, I would request you to please take this offline because this is a very specific question. And
Yeah.
like Doctor mentioned, you can probably seek consultation from her in RML and, as per her days. Because otherwise it will become she won't be able to advise you also, ma'am, on this public platform. So apologies for this, ma'am.
Yeah, thank you so much. The only thing is that sometimes, there are situations like I stay outside and they are dependent on me.
Yes.
So I also feel, sometimes I need an advice and I cannot rush to physically RML. So in that case, what should I be doing? And who is a good, in a parallel psychiatry or psychiatrist where we can go and consult, So
Sure.
that becomes a bit of a paradox, especially when you are dealing with psychiatry and Parkinson at the same time. The dosage are contradictory to each other. At the same time, both the conditions are severe conditions.
Yes,
So
ma'am.
it's very hard to balance out, and it's so difficult for us to make a decision without a doctor's support. So we
Sure,
have
ma'am.
to be rushing physically to RML. That is the only constraint. And yeah, we do really respect, and we really appreciate the way they deal with every patient.
Sure, ma'am.
The only thing is that
We can connect with you offline, and we can also recommend you other practitioners if you wish to see in your personal time. But right now I'll have to interrupt and, because I know
Sure.
Dr. Mina has
I do understand.
other
Yeah.
commitments as well. So, ma'am, just as we are winding this session, and it was a full power, we started at 6, and we have almost run over time. But, ma'am, any final words from both you and Jayashree on how you would, what are your recommendations about the management of Parkinson's disease and advice for the family members?
Yeah, so my advice to all the kind people who managed to stay through the whole program is Parkinson's is fine. It's just a disorder. Don't think about it as something very major. It's not like cancer. One is not going to die from it. It is just a disorder which needs treatment. Then so do most of the disorders. Most of the chronic disorders need treatment. Yes, you might have a good physician who might treat. You might need additional help from a neurologist or psychiatrist who would be seeing you once in a month, 3 months or so. So if we are able to minimize the aura of Parkinson's into, something which is just a disorder, which is incapacitating, but then there are treatments available, there are alternative therapies available, then one is able to put Parkinson's in perspective. And when we are able to put it in perspective, there are a lot of other symptoms like depression and anxiety. They get taken care of, and one can still lead a full and meaningful life, a joyous life, a socially engaged and productive life with Parkinson's. One should not fear Parkinson's. Yes, it is difficult, but it is not impossible. So, if you have, or if somebody in your family has Parkinson's, a little bit of support and a little bit of encouragement, medical help, complementary therapies will take you a long way. So, don't worry too much. That's my advice to both patients and caregivers.
Thank you, ma'am. Thank you for sharing this. Jayashree, would you like to come in and share your thoughts?
I think when we're talking about complementary therapies, there's just one thing that I want to point out or highlight really is that, this term complementary therapies, what do we mean by this really? It's a lot of these things that we're referring to as complementary therapies are actually things that a lot of people are practicing anyways. A lot of people are doing yoga, a lot of people do meditation. When we're talking about dance and music therapies, we're often involved with, during various functions or festivals, whether it is singing or bhajans or even just singing along with, your Bollywood music and all. This is all music. These are things that we do in our regular lives. What I think is important to remember is that if you're diagnosed with something like Parkinson's disease, that, as Dr. Mina was mentioning, that should not be the beginning to an end. You need to continue doing these activities which you're doing, and not stop them just because you have a diagnosis. The reason why we're now looking at the role of these specifically in research is because there's a lot of evidence to show that these are helpful. And even things like there's actually a very interesting study which is looking at the Garba dance, for example, in Parkinson's disease, and these are things which people do. These are part of festivals. These are things that people get involved with anyways. So I think just one advice would be don't stop doing things that you were doing routinely just because you have a diagnosis of something. Continue to do what you're doing, remain engaged, remain socially active. You may not be able to do it the way that you're doing as previously, but and you may need to change it to be a little more safer, but still continue to do a lot of the things that you're doing. It's good for you.
Thank you for sharing this, Jayashree. Thank you, Dr. Mina. Are you there? May I request you to switch on your video for just the last 1 minute? Thank you, everyone, for joining us today for this session. We had nuggets of wisdom and lots of knowledge, ma'am. And you put it in such simple words, which is what I really appreciated. And for everyone to understand the illness and not be scared about it and deal with it. Now, if it is manifesting, then all you can do is see how you can still continue to maintain your quality of life. And there are various treatment options available, like you mentioned. So with this, ma'am, thank you so much for coming on to our platform today and being a part of our webinar series on different aspects of active aging, mental health, which we keep doing from time to time. And we hope to invite you again sometime soon, later in the year. And thank you, Jayashree. And thanks everyone for being here today. May I request, if you like this session, you can just put in a Google review for us. Navya, can you just share the Google review link? And that would be wonderful. So thanks everyone for your time. Thank you, ma'am. Thanks once again.
Thank you so much. I had a wonderful time.
Thank you, ma'am.
All the very best.
Thank you so much. Thank you.
Thank you.
So.